let me ask, before we move along, some obvious questions which I suspect don't really have hard answers. Does metabolic syndrome lead to psoriasis, or does psoriasis lead to metabolic syndrome?
You know, I think from what I've heard from Joel, and putting things together with my understanding, there could be three things going on. One is the genetics could be causing both.
So lead to may not actually be the correct verb.
Yeah. And then you may have people with psoriasis who, you know, because of its effect on their psyche, their behavior changes in such a way that they become obese.
Right.
And then you could have people who start as obese, and the inflammatory influences of obesity lead to psoriasis. Okay. And so I suspect it's some component of all three.
Yeah, exactly. And I think clinically, I think it's not so important, actually, when it comes down to it. I think from a public health point of view, it's important to understand risk factors for psoriasis. We know from some well-done epidemiological studies that people who are overweight have higher rates of developing new onset psoriasis. So getting people to lose weight is probably a pretty important thing.
So just asking one question, I mean, there's an age component here as well. So, I mean, you can get this in pediatric age groups, but it seems that the incidence is higher as you get into the more, shall we say, senior population.
Well, this is really fascinating because, you know, it's a lifelong disease. Once you develop it, most people are affected for life. And so the frequency starts rising at its fastest, usually in late adolescence, early 20s, but continues to go up over time in people's lifetime. And I've had patients develop the disease in their mid-80s, usually in the setting of a major stressful life event, for example.
Well, knowing that now there is this relationship between metabolic syndrome and psoriasis, the obvious question is, do enough practitioners know about this? Are they out there monitoring for this, or is this something that's gone by the board?
Yeah, so as we know from a variety of research that's been done, so a lot of it in Europe, some in the United States, that this is an area that is under-evaluated in patients with psoriasis. They're under-screened for cardiovascular risk factors. When they have cardiovascular risk factors, they tend to be under-managed compared to other patients who have cardiovascular risk factors. So
are dermatologists more than others monitoring for this comorbidity? Or are they in the same bucket?
Yeah, so I think before this research is fairly new. We're coming out in the last 10 years or so. So the standard of care is slowly evolving. The new AAD MPF guidelines just came out in this, the first guideline ever from the AAD about comorbidities in psoriasis, and start educating our peers about either screening for cardiovascular risk factors or encouraging the patient to see their primary care doctor and have those screens done in primary care.
Well, let's just spell this out once and for all. The comorbidities and complications, if you have both metabolic syndrome and psoriasis, what are we looking at? Who wants to take that?
Well, I'll start, and maybe Steve could add to it. So one is when you're overweight or have metabolic disease, it makes psoriasis more challenging to treat. One is from a safety point of view. One of our gold standard drugs is methotrexate. Patients with psoriasis have higher rates of fatty liver disease that often makes them intolerant to methotrexate use over the long term, so it's more challenging to use. Some of our biologics that aren't weight-based and have lower efficacy don't work as well in people who are very overweight.
So maybe they should be weight-based.
Well, often when they're weight-based or some of the newer therapies that are so effective on their own, overcome that challenge. But we know patients who are heavier are likely to have a more challenging treatment course.
Okay, given this, given the need for practitioners to understand all this, do you guys have programs out there to educate practitioners about this? Are you paying for programs to do this?
From an insurer standpoint, that would be a great opportunity. I mean, I think
I call it the conditional there. The condition that would be a great opportunity.
So I think there is in general a great opportunity for insurers to, if you will, step up to the plate in a broader sense.
Sure.
And this is an area that, you know, frankly, before preparing for this conversation we're having this morning, I was not aware of that strong association between metabolic syndrome and psoriasis. So it's another one of those areas where we can put on that population health hat and we can start working down this pathway.
Are dermatologists as a group beginning to refer their patients with psoriasis and metabolic syndrome to cardiologists? Are they doing this?
You know, I think it's pretty variable, and it's one of the issues with healthcare across the country. As I'm sure as an insurer, it's something that you guys try to work on, is sort of having more standardized uptake of evidence-based principles, if you will. I think it's probably very different from doctor to doctor. Some dermatologists work in small practices. They may be more insulated, have a hard time working with a collaborator like that. I'm at a university center. We have a cardiovascular prevention clinic. Targeting patients with psoriasis for cardiovascular prevention is part of the new ACC AHA guidelines, so it's in the cardiology literature now. So they understand the importance of screening patients and looking at risk factor reduction in these patients.
Yeah, I think this is a new area for dermatology. We did some work some years ago looking at how often doctors of different specialties would even check up blood pressure on patients. And dermatologists were the third least likely specialty.
Is that right?
Yeah, behind psychiatrists and ophthalmologists. They were the only ones doing it less than we were.
Even my dentist checks my blood pressure.
That's great dentist.
No,
That's news.
From an evidence standpoint, I don't know that we have prospective studies yet that show that if a dermatologist sends patients to a cardiovascular specialist that the outcome is improved. I don't think we have data yet that says if dermatologists screen for metabolic syndrome that outcomes, short or long, or death rates are improved. I think it would be very hard to do those studies. And metabolic syndrome being so common, I don't know that I should be treating my heavy psoriasis patients any different than my heavy non-psoriasis patients. Maybe they should equally be sent over to at least their primary care doctor.
Right.
So I think to some extent dermatologists believe by the time you see us, you've probably seen a primary care doctor anyway.
But
they should be managing the cardiovascular issues.
But I think we've established they're not aware of that relationship.
Right. And also, often they think of the dermatologist as their doctor. Most patients, especially due to co-pays and how busy people are these days and hard accessing doctors, they're seeing a dermatologist for psoriasis. That's the only doctor they're seeing. And so there's a lot of undiagnosed hypertension in these patients, a lot of undiagnosed dyslipidemias and things of that nature.
Before you throw me off the stage here, I just
that's not going to happen.
Okay, I'm just curious. Would kind of in the best case, or one scenario would be where a dermatologist's office actually has somebody within their office who's maybe the metabolic syndrome specialist, not necessarily another physician, maybe an advanced practice nurse, maybe an RN level nursing, could help to manage those aspects of metabolic syndrome. Is that something that you would see as a possibility in this space?
I think it's certainly a possibility. I think the challenge is that dermatology practice is set up to deal with dermatologic conditions, and it's a lot of them.
Yes.
Cancers, serious problems like melanomas, other inflammatory diseases. We treat dozens, if not hundreds, of different conditions of the skin.
Or thousands.
That's
or
right.
Thousands.
Yes. So that makes it challenging operationally, I'd say, but also being patient-centered.